Good afternoon, everybody, and thank you for the very kind introduction. So, the title I chose is Diabetes Prevention in 2018, a look back and a look ahead. And I have been fortunate to be part of the diabetes prevention program, and we now have 20 years of follow-up of people with pre-diabetes to see how the disease progresses. So, first of all, my conflict of interest disclosures are up here. These are the objectives which I hope to convince you. First, I will discuss the rationale for diabetes prevention. Why should we prevent the disease? Somebody's going to get it, they'll get it, and we'll treat them when they get it. Is there a rationale? Then, okay, if we do want to screen, who should we screen? Which tests should we use? Fasting, OGTT, A1C? Then I will describe for you these 3 studies with which I have been associated. The Diabetes Prevention Program, and it is continuing as the Diabetes Prevention Program Outcome Study and the Actos Now study. And finally, bottom line, what does it mean for the patients that you see who do not yet have diabetes, and especially in the Indian context? So the first question I think we should ask ourselves is, why should we prevent diabetes? Well, if we look at the natural history of type 2 diabetes, before people go to diabetes, they stay in this state of impaired glucose tolerance, they're insulin resistant, dyslipidemic, the beta cell begins to fail, and then you get diabetes. Blood sugar starts to climb, and various complications can develop, macrovascular, microvascular. They cause a lot of disability in the form of blindness, renal failure, amputation, CVD, ultimately premature cardiovascular death. As we all know, it has been estimated about 5 to 8 years of your life is reduced with diabetes. So the advantages of detecting and treating is one, you can reduce the amount of people. People with diabetes cost much more money. It's almost about 5 to 10 times the amount. So if in the US, the per patient cost, if you don't have diabetes, is like $2,000 a year. If you have diabetes, it goes up to about $10,000 because you have a lot more complications. And maybe if we prevent diabetes, maybe we will reduce microvascular, macrovascular complications. So if you step back and look at the numbers of the International Diabetes Federation, the 6th edition, India is always right up there, very close after China. 2013, 2035, it is projected that the number of people with diabetes in India will increase from 65 million to about 109 million people. The United States, it's China, India, and the United States there. But what is more important is the total adult population this is in the age group 20 to 79, is about 800 million. Those with diabetes, about 8% prevalence. And if you look at the total number of cases, it's estimated, that's the number which is estimated. And about, people who are diagnosed, and this is, 36 million. That's not the 3 more zeros there. But look at these statistics. The number of deaths is estimated at about 1 million. And most importantly, there is a cost associated with it. And that is about, that's the numbers they give in US dollars for a person in India. This was published by Mohan, and he says the demography of India is changing. If you look at diabetes in the year 1966 to 1971, rural India, what you see in green, that's about 0.3 to 0.9% in the states, Andhra Pradesh and Odisha. Whereas in the urban areas, there were much more people, and now we see the yellow there, 4% to 6.9%. That was between the years 66 to 1975. Now, in 2014, when they looked at it, rural, look at it, lot more green, red's coming in now, more than 12%. This is in rural areas, not in the urban areas. And if you look at urban, of course, it's very little of the low prevalence thing, much more of all the high risk over there. So there is a problem. It is increasing. Now you can say there's a detection bias. We're doing more, tests and all. That may be there. But it was so that even Nature, they put out and they gave this India's diabetes time bomb. And what they say is epigenetics and lifestyle are conspiring to inflict a massive epidemic of type 2 diabetes in the subcontinent. And they said growing wealth is compromising India's health. And as you know, the INDIEP study, again, Mohan's actually my classmate from 45, 50 years ago. We were together in college. And they've looked at diabetes, pre-diabetes in 15 states in India. So what did they see? They said they looked at GDP as a measure of your economic prosperity and how much diabetes they have. So let's look at the GDP in US dollars. Bihar is at the bottom of those 15 states, about GDP 500 US dollars per year. And if you go up, Chandigarh has got the highest with a GDP of 3,500 US dollars. So people are more well off over there. But unfortunately, look at the prevalence of diabetes. In Bihar, with the low GDP, the prevalence is about 4.3%. And as the prosperity goes up, it's 13.6 in Chandigarh. And Maharashtra is over there, 8.4%. So this is clearly seen. The more prosperous you become, you have more money, you go, people go out, eat fast food, eat whatever there is to do. So what can we do? We can screen and identify people with prediabetes and treat them so that they do not go on to get diabetes. But how do we find them? I mean, if I look in this room, guess how many of you might have prediabetes and not even know it? A lot, including me. Okay. So this was Mohan's the cure study, and he said how much of it is preventable. And what they said is, if you have these 5 risk factors, that will explain about 80% of all incident diabetes. Obesity, physical inactivity, they define that as sitting for more than 3 hours. I've been sitting for more than 3 hours today. Watching TV, everybody in the evening is watching some serial or the other. Poor diet, more of refined cereal, less of fruits, vegetables, dairy, high triglycerides. Most Indians have triglyceride if you do it fasting more than 150, and a low HDL. That somehow this Indian thin fat is high triglycerides, low HDL. And Mohan has postulated this Indian diabetes risk score depending on age, waist circumference, physical activity, and family history. These are the common predictors over there. And if your score is more than 60, he says you should do an OGTT. If that's not possible, which it is not, at least do a random or a fasting blood sugar to find out what is the risk. 30 to 50, he says, you have a moderate risk of diabetes. Do an OGTT, a random sugar of fasting blood sugar. And if it's less than 30, you don't need. So there are some parameters by which you say, okay, I think I need to test you. Which test should you use? Well, a screening test should best predict diabetes and be feasible on a large scale. There's no point of having a very sophisticated test. If it costs so much money, you cannot do it on a large scale. The OGTT is still the gold standard, but it is less reproducible, and a lot of people don't realize this. We did these studies in San Diego almost 25 years ago. If you take a group of people, repeat the OGTT with everything else being equal 2 weeks later, the coefficient of variation is about 35%. So people move this way, that way. On one occasion you say, hey, you have diabetes. Second time, no, you're normal. And that keeps moving. And it's also difficult to perform on a large scale. Guess which is far more stable? Fasting glucose. That is very tightly regulated by the liver. When you fast overnight, the liver has got a very tight control on the glucose. Far more reproducible, and on a day-to-day basis, it's not. It's about 10-15%. I mean, it bounces a little bit, but and it's easy to do. You can do a fasting glucose. And last but not the least, the A1C is also more reproducible. It's easier to perform. It's expensive. So you have to find out which one. And there is various predictions that if you do the one which probably goes up first is this 2-hour post-challenge glucose. After that, the fasting goes up, and after that, the A1C goes up. I have patients in the diabetes prevention program. So these patients, the fasting blood sugar is maybe 118 or 120, pre-diabetes. The 2-hour OGTT is 210. diabetes. The A1C is 5.6, normal glucose tolerance. What do I tell that patient? So there are recommendations. Now, which test should I repeat again? Oh, I might do the A1C. It's far easier to tell. The recommendation is do the more abnormal test and believe that test. So there are some guidelines, but sometimes you can't tell. What do I tell a person? And of course, just for, to remember, fasting glucose, those are the numbers. OGTT, it's 140, and then A1C 5.7 to 6.4 is pre-diabetes. Okay, so now we have got the people, we have, found who they are. How do we treat them? And these are all the intensive lifestyle studies. You can look at there, Daching, Finnish. I was part of the US Diabetes Prevention Program. 58% reduction in progression to diabetes. I'll talk about the Indian Diabetes Prevention Program, which Mohan did, and the other studies. If you use, nobody likes to go sit in the, I can't go to the gym. I want something, give me a pill, I'll take it, and I want to be good. So, the US Diabetes Prevention Program, metformin works, and I'll show you the data again. Indian Diabetes Prevention Program, about the same, 28-30% reduction. Other studies are there. And Actos Now, pretty good. I have to change that number. It's not 80%. In our reanalysis, it was 72%. So, the Diabetes Prevention Program was stopped in February 2002 because the NIH said, you know what, lifestyle works so well, so we can't continue the study anymore. We need to give everybody. What were the results? So if you look at the cases per 100 patient years, placebo 11% per year with pre-diabetes go on to get diabetes. If you use metformin, we use 850 BID, reduced by 31%. Intensive lifestyle, 58% reduction. So pretty good. How much weight did they have to lose? The goal was 7%, but they lost only 5%. So a person who, say, 100 kilos needs to lose 5 kilos. I'm saying it's easy. It's not easy. It's difficult. But we published a 10-year follow-up in Lancet. We published a 15 years follow-up, again in Lancet. Don't ask me why New England Journal of Medicine. There's a lot of politics there. Anyway, but that's what it is. So let me show you the weight loss. Okay, this is change in weight. Baseline weight was 94 kilos. Lifestyle brings it down by about 7 kilos. Then what happens? By the time the DPP is over, you're coming back up. Then you level, and then you're down about 3 kilos. This is all the people we have. We have very good follow-up. They have almost 90%. Metformin, not so much, about a 2 kilo. But it levels off and goes down. Placebo, they don't lose much weight. They come down. Guess what? Almost everybody is in the same thing now. 18 years on, and this is the other thing which people say, as we grow older, we all put on weight. No. By the time you're 30, 40, you stabilize. And then, actually the data, this is the data, we check this very carefully. We start to go down in weight. That's what happens with most people. But you shift between fat and muscle. That is known over there. But this is the data that we have. What about diabetes development? Okay. So this is, again, cumulative incidence. Placebo, lifestyle, metformin, conversion to diabetes. Initially, these were the conversion rates, 29, 22, and 15. That's a 58% reduction. When we published the 10-year data, 55, 48, 44%. Don't worry about the numbers. 15 years, 60, 59, 52. So people with pre-diabetes, you diagnose them, you do something. Initially, there's a very sharp increase. It levels off, and then it is flattening. And that's what it's doing. So maybe we are now 18 years out, and it's about 64%. So the bottom line is not everybody with deep pre-diabetes will go on to get diabetes. No. Some people will go back, 15, 20%. Many people stay over there. So we cannot really, but we don't know upfront who's going to get the diabetes or not. So the conclusion in the 15-year follow-up, we said, neither lifestyle nor metformin was associated with reduced microvascular complications. So it didn't matter that we prevented diabetes. There was no difference in microvascular. What they did find was, if you did not get diabetes, there was a 28% lower risk of microvascular complications, independent of which group you were in. Even if you were in the placebo group, if you didn't get diabetes, you got less micro. So what you did not seem to matter here. Surprisingly, we cannot explain this. In women, lifestyle seem to work. So always when you get these gender things, it's very difficult. You got to look at the data more carefully. Actos now. We did it, 72% reduction, but weight gain, edema, and fractures, which was there. We had 84 people, 5 women developed Colles fractures and all that. So it's a good drug, and we use 45 milligrams, which many people do not use. Well, we need to make in India. So the Indian DPP-1 was published in Diabetologia, and what did they show? Control group, 55% converting to diabetes, reduced by lifestyle modification to 39%, metformin 40%, and in the Indian DPP, they did the combination of metformin and exercise, which we couldn't do. It's too expensive to do it in the thing. Conversion is very high. In the other one, I showed you 29. This is 55%. Progression is similar, whether you use lifestyle or metformin, it's about 28%. We showed 58% with lifestyle. And if you gave the two together, it did not matter. But let me tell you one thing. The dose of metformin was 250 milligrams BID. And I asked Dr. Ramachandran why. He said they used 500 BID. This is his answer to me. It's in the paper. People got hypoglycemia. Okay, so metformin doesn't cause hypoglycemia. But I'm just telling you what was there in the paper. Ramachandran also did the IDPP-2, which was pioglitazone. Pioglitazone did not enhance lifestyle modifications. And if you looked at the primary outcome, lifestyle and placebo, 31% went on to get diabetes. You added pioglitazone, it did not work over and above that. Why this happened, we don't know. If it is, we have different ethnic, it's possible, and we need to look at it. And I really would encourage people here, even in the clinics that you see, you can at least do observational data. Some data is better than nothing, because always in the West they will say, show me the data. And data is quite powerful. So this is again Mohan's. There's a mosquito sitting right in front of me. I don't want to get bitten by a mosquito over here. All right, sorry. The DCLIP study. So this was quite an interesting study which he published in Diabetes Care. He took about 600 people in Chennai with either IGT, IFG, or the combination of the two, and he gave them standard lifestyle. What do we tell people? Watch your diet, do lifestyle. We don't tell them more than that. Go see the dietitian or go somewhere and do it. But he did another 6 months, culturally tailored, like the US DPP, and he also added on metformin as they kept progressing up there for patients at highest risk at 4 months of follow-up, and he looked at diabetes incidence. What did he find? Cumulative incidence of diabetes over 3 years was 35% in the control group and 25% in the group that he intervened. So there's quite a good relative risk reduction of 32. But remember, 25% means 75%. It really, there was no effect. So what about using the internet and mobile? Apparently, India has crossed 1 billion these things. And overall, it's 80%, but even in rural areas. I did not know this, that people in rural areas also carry the cell phones. And Ramachandran did this. He looked to see, every day you send a message to the guy, hey, did you check your sugar? Or, did you exercise at the evening? Did you exercise for 30 minutes? If not, go and do it now. Or did you watch your diet? So they used to send a message in the morning. They used to send a message. And it helps. We all know when we were young, your mother wakes you up, do this, do that. Little bit, most of it we do. We don't do everything. But it always helps to have a reminder. Otherwise, out of sight, out of mind, nobody wants to do. It showed that really it works. There was a relative risk reduction of 36%. So if you even do, just send a message to them, hey, you need to watch your rice, the guy, I'm just going to a wedding, I'm going to eat what I'm going to do. Yeah, but watch what you're eating. Don't eat those laddus, don't eat this and that. Anyway, is it worth preventing diabetes? I know this is controversial. I've got some controversial people who are going to ask me questions. Does it really matter? Okay, let me go back to what I said in the beginning. The advantages of detecting and treating is to reduce the cumulative incidence of diabetes. Can we do that? Yes. I've shown you the numbers. In the early years which you do it, you get the low-hanging fruit. You can prevent it. After that, life gets in the way. Everybody progresses, and some people are never going to get it. And we Any decrease in complications? No, no, no. I've shown you the data for the DBS. And we look very carefully. We look into the eye. We do fundus photography. We do this, the Minnesota scale for neuropathy. We do everything. We cannot pick up any difference over there. I'm being a little skeptical, but this is there. But, in fact, we were talking about genetics and all that. There was a study done in which they took people and they did these genetic polymorphisms, that TCF7 like 2. And so one group of 50 people, they said, you know what, you have this polymorph, you're going to get diabetes. Almost there. The other group, they didn't tell them. They followed them for 6 years. It didn't matter whether you tell people you will get diabetes. I mean, you can look at a person, if he's big, you're going to say, it does not matter. People will do what they will do. And I've shown you the metformin data, I've shown you the lifestyle data, I've shown you 18 years of data. It's all coming together. But in the meantime, what can we do? Well, I think we can provide adequate facilities for recreational, urban and rural. It's not easy. I looked out of my window today. There is a concrete jungle out there. Is it the Mula or the Muta, the river? I don't know which one it is. There is no river. It is flooded. There's nothing. It's a concrete jungle that's out there. How are we going to do it? Even in rural areas, it's there. But we need to do, and it needs to be safe. You go out in Chennai in the morning, 6 o'clock, you'll get mugged. People, snatch your phone or whatever. I'm kind of trying to be a little skeptical, but it is what it is. It's not easy. And Mohan and all have done it, so they have parks and they make people go around the park. But, mosquitoes biting me here. It's going to bite me over there, wherever, whatever. We can encourage walking, cycling rather than mechanized transport. I was coming in the car from Bombay to Pune, and the driver was telling me, he says, when I used to go to school, I used to walk 5 kilometers. Now my son, for 1 kilometer, he says, Papa, give me money, I need to take a bus or a thing. He says he doesn't want to walk even 1 kilometer, let alone 5 kilometers over there. And of course, everybody has got cars and everything, we do it. I think we should discourage consumption of junk food. How? Taxation works in New York and all that. They have seen that right from cigarettes, if you increase the tax, it comes down. I don't know why. The guy who's going to do it is going to do it, but it brings it down. You increase the sugar tax, as they call it, it brings it down. And in fact, actually, in the Los Angeles school district, this was a major effort. They banned all soft drinks in the school. They said, you just give water. It was a huge fight because guess, if you've heard the US nutrition guidelines, which everybody follows, how much salt, how much fat, how much cholesterol, guess who writes it? The Department of Agriculture, okay? And you've all seen, the salt, the sugar consumption, they've gone back on it. In fact, the person who wrote the sodium guidelines, she works in San Diego. And there was an editorial after that. It was all diluted out by the time it came. And this is the words which were used. The US nutrition guidelines have got the paw prints of the US cattle industry and the fingerprints of the US sugar and confectionery industry. They decide what you put in there. They are not going to let you take this away, take that away. How are they going to make money? Anyway, I'm saying, how are we going to do it? I don't know. Ensure availability of healthy foods, fresh fruit and vegetables at affordable prices. We can't do that. How do you do it? You tell your patients eat healthy. Like in the US, I tell them, he says, Doc, are you kidding me? He says, for $1 I can get 2 burgers. Am I going to spend $5 to get $5 to get? No, I've got to eat. I'm going to eat what I can get for a cheap price over there. Encourage healthy eating practices. And I'm not saying this. Efforts are going on in the school. We have to teach the kids and all that this is there. And I showed you the data for mobile. Everybody's got a mobile phone now. Maybe we can use it to make people feel a little more guilty. Don't eat this, don't eat that, and we might do. But I myself went and had the rasmalai. I'm not supposed to eat rasam, but it is over there. It is inviting me. I don't know. Maybe we shouldn't have kept it. And nowadays, in many of the meetings, they serve only healthy food. They put that. Now, if you put a calorie thing there, this has got 5,000 calories and it's got 70%. Nobody will have it. What's that? If you do it, it'll do. It's like, have you seen these glucose meter ads? What do they show? 89 milligrams, 87, 92. Have you ever seen a glucose meter which says 385 milligrams? They will never put because that meter will not sell. Because people think if I get that meter, I'll get a blood sugar 385. Anyway, What's the role of metformin? I don't know. You saw the data. They use 250 BID because metformin, it's there in the paper, causes hypoglycemia. I don't know that. Pioglitazone is good. It works. But as I told you, my bias, I was telling you is that 72% reduction, but there's edema, there's weight gain, and in perimenopausal, postmenopausal women, I had, out of 84 patients, bias. 5 patients had fractures. How do I explain to them, you take Pio, you won't get diabetes, but you'll break your leg? I don't know what to do that. This I downloaded from the US. I think the key to preventing diabetes can be boiled down to 5 words. Can anybody guess what those 5 words are? Stay lean and stay active. I think we can all do it on our own. And, in the previous session, Dr. Neeta Deshpande was saying, if you come down from a BMI of 23, which is not big, to 21, that is, you're staying lean. So wherever you're on the curve, try and lose. The magic number is 5%. Now, where do we get the 5% from? Because studies have shown that there's metabolic benefits of that. But that's not to say that if you lose 1%, 2%, you will not get. You will get, but it may not be as much as you will do. So I think together we all can prevent it. We all have to do something in our own words. So with that, thank you very much for your attention.
Thank you, Sunder. With this last slide, you say, I can prevent diabetes of other people or I can prevent for myself. Not clear.
For both. For me and for you.
So, as you took part in DPP, after that and ADA took up in a big way, stop diabetes and all that, how much it was effective in your own clinic, first degree relative population of where therapeutic intervention of lifestyle, as you highlighted, could be done more effectively? Does it have made any impact in US after DPP-4? Prevalence is still the same, people...
The prevalence, yeah. Actually, I have 4 minutes left. I would have put in more slides. I didn't. See,
so you allowed a question.
The big problem in India is, I should have put that slide in there. So we go from normal glucose tolerance to impaired glucose tolerance to diabetes. In the US, prevalence of diabetes, if you look at the numbers, it's about 29, 30 million. But prevalence of pre-diabetes is about 90 million. So about half the population has some degree. But in India, about 70 million have it. But the pre-diabetes is very small. And I have talked to Mohan for the last 50, I said, this doesn't make sense. He says it makes sense because in India, you don't spend too much time in that pre-diabetes phase. You go very rapidly through to the diabetes phase. What's that?
It's also underdiagnosed.
Possible.
Maybe, but those who are diagnosed are to be intervened very, very quickly, effectively, because the time is short.
But see, IDPP and all, they don't have the follow-up. We have good follow-up. Luckily, we still have money for another 5 years. So it's paid my salary for a long time, the diabetes prevention program. Yeah.
I do.
I do. I use it in myself to prevent diabetes. No difficult questions. No drug is approved at all. In the US, we are trying to get metformin. There is no manufacturer who will come. Actually, I was one of 200 people who signed the public petition to get metformin use till an EGFR of 30. Nobody wants to do it.
But do people in the US use metformin off-label?
Yes, absolutely.
What about acarbose being used off-label?
Okay, acarbose, I had lot. The Stop NIDM study was there. Just last year, they published the ACE, acarbose and cardiovascular. Nothing.
No, but the prevention of diabetes.
But that's what the question I ask is, so what if you prevent it? How does it matter where you're sitting? If you can't prevent microvascular, if you can't, is it worth it? I'm just posing the question. I do not know the answer. Okay, thank you.
Thank you, Doctor.